open ಮಾಡೋಗಿಲ್ಲ ಆಯ್ತಾ? Right? Stay number clear.
Shena.
ಇದು ಸೆಪರೇಟ್ ಆಗಿ ಫೈಲ್ ಟೈಪ್ ಮಾಡೋಕ್ಕಾಗುತ್ತಲ್ಲ? ಇದರಲ್ಲಿ ಇದೆ ಫೈಲ್ ಇದೆ
ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಇದೆ.
Good evening, sir. Good evening, Ravindranath. Good afternoon, Ravindranath, sir.
Good afternoon, Jayesh. Jayesh, right?
Jayesh, yes, sir. Yes, sir. Exactly.
Sir, morning.
Yeah, did you get a call from Shiraz?
Yes, sir, he called me. He said,
Yeah.
depending on his posting of the case, he will decide where to speak.
Yeah, you decide what who does first. I will do the last. So you can get ready to. I mean, is he presenting
afternoon, sir.
first? You are presenting first.
Will I share the screen, sir?
No. Are you presenting first, or Shiraz is presenting first?
I'll be presenting first, sir.
Shiraz,
I'll be presenting.
you will be okay. So get ready. We should be starting soon.
Fine.
I'll just come back in a minute or two.
सतीश भाई कैसे हो?
Yeah, मैं तो ठीक हूँ. I'm fine. We are just trying to sort out some messages which were coming in, and
Right.
okay, I think Ravindra, you should probably start within a minute or two. I'll just ask our colleague Jayesh or
Satish,
Yes,
you
sir.
should ask everybody to put their names, you know.
sorry.
They should put your names, you know. Everybody should put their names in the bottom.
Yeah. I know. That creates a bit of a issue because otherwise these numbers or the cell numbers are a little misleading. We don't really
Yeah.
know who is who. So I think Jayesh, we can start. You can set up, and within a minute you can start. We are
Yes, sir, we still have 2 minutes. We'll wait for 2 minutes, and we can start exactly at 3.
yeah, sure.
So should I start now?
Yeah, we should.
Yeah, okay, sir. So, good afternoon, everyone. I once again take this opportunity on behalf of Alembic to welcome you all for this seminar on mission spine. And as we all know that we have a series of transforaminal lumbar stenosis surgery, stitchless and under local going on, which we have recently completed 2 lectures. Today is the third webinar, and today's topic is going to be on imaging in stenosis. Imaging in stenosis, and for the same, we have Dr. Satish Chandra Gore sir as a moderator with us present today. I welcome you, sir. And we also have eminent faculties from Mission Spine, Dr. Shiraj Ahmed Munshi sir and Dr. Ravindranath sir as an eminent speakers from Mission Spine Foundation. So I take this opportunity to welcome Dr. Shiraj and Ravindranath sir. And without further ado, I'd like to hand over the session to Dr. Ravindranath sir for the session talk. So over to you, sir.
Thank you, Jayesh. I'll just share my screen. Sir, it is the screen is seen now.
Yeah, we are able to see you well, and we are also hearing you okay. So you can go ahead.
Thank you, Dr. Gore sir, for asking me to speak on important topic of imaging in lumbar stenosis. And I thank Jayesh as well from Alembic for giving this platform. It's an excellent platform to communicate with each other. I'll be dealing with imaging in lumbar canal stenosis, and we'll be dealing with the many modalities of imaging, and more commonly in clinical settings, we are more familiar with starting with the X-rays, where in canal stenosis they can give some information about the alignment of the vertebrae, about the degenerative changes, say the end plate levels and in the facet joints, which you see in the form of an osteophytes, end plate osteophytes, which can encroach into the spinal canal and cause stenosis in that area. Now, we also have CT scans, but the CT scan can allow some, can give us some soft tissue delineation where we can appreciate some changes in the discs as well as a bit of soft tissues, maybe the ligamentum flavum and all. But nothing comparable to MRI as such. We can get some additional information by using a contrast, where we can appreciate the epidural venous plexus, which sometimes are important when we have features of radiculopathy, because these signify the presence of granulation tissues between the annular tears and the nerve roots. CT myelo, which is comparable to MRI as per the sensitivity of the reports is concerned, but as such, it's an invasive procedure. And even though it delineates the nerves and nerve impingement, as well as give adequate information about stenosis, CT myelo has not gained as much popularity among clinicians as MRI. So the advantages, MRI is actually, in fact, the modality of choice when it comes to imaging lumbar spine or cervical spine. It's a modality of choice because the main reason being it's non-invasive, and there is high sensitivity in diagnosing stenosis because of the excellent delineation between the bone and soft tissue structures. High soft tissue contrast, where you can delineate the fat from the water, and so nerve roots, CSF, ligamentum flavum, and even the osteophytes also can be covered to some extent. It best depicts the cord, the nerve roots, flavum, and bone marrow abnormalities as well. And the biggest advantage being there's no radiation here, so it's convenient for the patient as well. The most commonly used sequences are the T1, T2 weighted images of sagittal and coronal, sagittal and coronal planes. These give an idea about the fat and the water and the fluid distribution, and the changes in these images give us an adequate information about the environment around the cord and the nerve roots. Stir images are short T1 inversion recovery images. They are mainly used to null the intensity of a fat signal, and they're not of much use when it comes to stenosis. Similarly, even the proton density weighted images are also not much useful when it comes to stenosis, because it's mainly based on the distribution of the hydrogen atoms which are there in the bone as well as in the soft tissues, and they are excellent in when you want to do an MRI of peripheral joints and extremities. But when it comes to the lumbar spine, they don't have much role to play there. We can use a contrast, using a gadolinium contrast in MRI in cases of suspecting infections, tumors, or any, as I mentioned, with the contrast enhanced CT scan. Even the epidural plexus around the cord and the disc can be better delineated with a contrast enhanced MRI. Now, one of the sequences which can be useful in canal stenosis is diffusion tensor imaging, which is one of the way of doing an MRI apart from the conventional MRI what we see. And this, in fact, measures the diffusion of water or fluid along the nerve tracts and in the tissues and the surrounding tissues surrounding the cord and the cauda equina. Now, anywhere there is a breakage, say in a trauma, cord injury, or if there's an external pressure on the blood flow in the blood vessels or on the CSF. So this imaging can be helpful. It has not been used extensively in case of coronal stenosis, but I think clinicians and regulars should get together to see the usage of this type of imaging to clearly understand, or to see the exact level of stenosis, or to see the structures which are causing the stenosis. It could be much useful in future. So my own radiologist, I had a few discussions with him, and he doesn't see a reason why this cannot be used. When it comes to coronal MRI images, again, we concentrate on, we look at some coronal oblique MRI images, which is usually done in the plane of SI joint. Normally, we do it in the level of the plane of disc, but then this additional MRI image can give us much information about the ligamentum flavum extending from the tip of the SAP to the pedicle, to the upper pedicle. So it covers the upper and middle zones, and this is the portion of the ligamentum flavum which commonly compresses onto the exiting root just under the pedicle and gives rise to symptoms. So an information about that area can be very valuable in treating stenosis and formulating a strategy, formulating a treatment to relief of lateral canal stenosis. Ideally, this is the earlier version of looking at stenosis in MRI imaging, where the zones in the sagittal plane were divided into suprapedicle, pedicle, infrapedicle, and at the disc level. And any changes happening around this area were considered, were taken into account, and a few criteria like the quantitative and qualitative criteria were formulated, which I come to it later on. And similarly, in coronal views, we have the central canal and the three zones of the lateral canal, meaning the subarticular zone or the lateral recess zone, foraminal zone, and extrafemoral zone. So any changes or any obstructing structures around this area gives rise to symptoms accordingly. Now, before we go into the criteria, MRI criteria to diagnose lumbar canal stenosis, I would like just throw a few points about how exactly the disc or the changes in the disc or the contributing factors in stenosis look like. Now, there is a difference in the way a traditional surgeon looks at an MRI and an endoscopic surgeon looks at an MRI. And this is, I'm talking about myself, because when I was doing open surgeries, the way I used to look at MRI was much different. And now when I started doing endoscopic surgeries, the way I look at it, the way I observe the things is vastly different. And I bring to your attention, can just have a look at this image. Now there are three colors here, and one is the brighter one, a jet black one, and a grayish. Now these signify the brighter one signifies a tear in the annulus along with the formation of some granulation tissue. So the water content gives a bright signal. Then the jet black one indicates collagenase to the annulus which was torn repeatedly, healed, torn again, healed, with collagen formation, gives rise to this type of a picture where it is jet black, and this signifies collagenase of the annulus. Similarly, this can get calcified and ossified later on as well. The grayish area depicts the soft tissue, soft fragment, and what you see a cleft running from the upper end plate across from the center, right across the soft tissue fragments, coming up to the periphery of the disc. Now this is the tear, another tear through which the chemicals leak out and can cause the symptoms. Similarly, the same picture in the coronal views, and you can see the tear there. That is the collagenized annulus. You can see a collagenized annulus. You can see a small break there. So, and this is the soft tissue fragment. The right picture depicts the canal. You can see the brighter image here indicates the intraforaminal fat. And as you come down, you can see the foraminal fat has decreased in amount. This, in fact, is a post-operative image. This patient was operated some 3 years back, and that's why you see the deficiency of levantum flavum. She underwent surgery for canal stenosis, and here there's no levantum flavum at all. But then she has come back with symptoms again. She was operated elsewhere around 3-4 years back, and that is a nerve root. That is a disc, and which is coming directly pressing on the nerve root. Now, these are the pictures which we do not routinely observe if you are into a traditional surgeon. But when you become an endoscopic surgeon, then these pictures, these images give a lot of information as to the symptoms the patient is displaying. And whenever you want to treat this patient endoscopically, these images are important, because only then you formulate your strategy of what, when you go inside, what you're going to do, how much you're going to tackle the disc, how much tackle the other tissues around the nerve root, and your end point of surgery as well. And continuing with that, then you see the osteophytes and the facets. There's an osteophyte coming from the end plate, and it grows within fractions per, and with repeated calcification and ossification, they form into an osteophyte. You can see from upper end plate and the lower end plate as well. And there's a soft tissue fragment. There is annulus again. You can see the jet black color. There's a collagen annulus again. And now in the coronal view, you can appreciate the osteophyte here, which is in the subarticular region in the lateral recess, and the femoral region. You can see collagenous annulus as well. This area. When it comes to facets, it's important to note the wet facet sign, which indicates instability at that level, and you can appreciate even an osteophyte from one of the facets that is encroaching into the foraminal canal. So this information is very important because most of the patients have lateral canal stenosis, which was earlier missed when we were traditional surgeons. But then most of the symptoms of lumbar canal stenosis arise because of the changes in the lateral canal and the subarticular region. So the osteophytes in this area are very, very important, and osteophyte in the center may not be that important, but then in this area it's very important. Unless you take out these osteophytes, these keep compressing the traversing route, and any osteophyte in the foraminal region or around this area can compress the exiting route in the foramen and extraforaminal region, and can continue producing the symptoms even though you have done a central decompression and removal of the ligamentum flavum. Now, how the ligamentum flavum looks like. Now, this was what I was mentioning about the coronal oblique tube, where you can see the extent of ligamentum flavum extending from the inner surface of the lamina up to the pedicle. So, this portion of ligamentum flavum, in fact, compresses the exiting route, which goes just under the pedicle, and is one of the most important structure to be dealt with when you are trying to relieve symptoms of lateral canal stenosis. Now, again, I'll come back to this picture. And as we know, the ligamentum flavum, the early descriptions of ligamentum flavum, it was when it was described in 1939. It was described as a structure which extends from the anterior-inferior portion of intersurface of the upper lamina to the posterior superior surface of the inferior lamina. This is all what we were knowing about. But then in 1990s, again, a study divided ligamentum flavum into three levels, saying there are three components of ligamentum flavum. There's interspinalis, interlaminar, and intercapsular. The names indicate the location of ligamentum flavum. And again, there is another study which said there are two layers, superficial and deep layers. But then the extent of ligamentum flavum into the foramen or across the foramen was never discussed. And this one paper in 2014, where they did a study, they did a cadaver dissection study of around 140 people, and they found out that there are three types of ligamentum flavum. The type A ligamentum flavum extends from the inner surface of the lamina and ends just before the foramen starts. That you can say around in the subarticular region, around the medial margin of the foramen. So this type of ligamentum flavum is seen in only 2% of the cases. So out of the 140 cases what they dissected, they found it's only 2% they could make out this type of ligamentum flavum. The second type is the B type of ligamentum flavum, where the flavum extends from the inner surface across the foramen into the foramen and ends at the lateral margin of the foramen. This accounts to around 42% of the cases. So 40% of the people had this type of ligamentum flavum. The third type is the most commonest type, where the ligamentum extends from the inner lamina through the foramen and extends beyond the lateral margin of the internal foramen. And this type of ligamentum flavum is the one associated with the symptoms of canal stenosis. You can see the ligamentum flavum extending posteriorly and inferiorly as well. And as it encroaches and as it hypertrophies, and this occupies more of the space in the canal, giving rise to symptoms of lateral canal stenosis. So with this additional information, now we can conclude that it's not only the central portion of the ligamentum flavum which is producing the symptoms. It is that portion of the flavum which is extending into the foramen, thereby compressing the traversing as well as the exiting routes and reducing the volume of the lateral canal, which is more important, which is more which needs to be dealt for removing the symptom, for solving the symptoms of stenosis. Now, there was a lot of confusion among the radiologists and regarding the reporting on lumbar canal stenosis, because there were no fixed criteria as such to quantify or to say, like, if you have these features, then the patient has canal stenosis. So an attempt was made, that was in 2012, and where they had prepared a questionnaire. This is called it's called a Delphi survey, or they call it a Delphi design. And they prepared a questionnaire, and it was circulated to around 27 musculoskeletal radiologists. And out of that, they had mentioned some criteria under quantitative criteria and qualitative criteria. And all the radiologists were asked to give their give their credit scores in the whether which they will feel like authentic in reporting lumbar canal stenosis, which are found to be seen in many cases what they reported. So I'll just mention the quantitative criteria now, because these are the common things which you find in a report, and the most common thing being in the anteroposterior diameter of the osseous spinal canal. And I'm sure this is the only reading what you get in the MRI report right now, and we usually use this measurement to convince the patient, to tell the patient, saying that if the measurement is below 10, or if it comes to 8, 7, 5, so we boldly tell the patient that there's a decrease in the canal volume, there's a compression in the canal, so you need to undergo the surgery. Right now, this is the only measurement which even the radiologists and the clinicians have been using to convince the patient to undergo surgery. And the second point is the ligament interface distance, that is between the ligamentum flavum at the level of the facet joints. The third measurement being the transverse diameter of the osseous spine, the osseous spinal canal. The fourth is the AP diameter of the dural sac as such. Fifth is the height of the lateral recess, and if the height of the lateral recess is less than 3 mm, it is considered that the patient is having canal stenosis. And sixth point is the lateral recess angle, and if the lateral recess angle was found to be less than 30, then the patient was suspected to be having stenosis. Seventh is the cross-sectional area of the dural sac, and again, 8th point is the portion of the actual the rootlets, the cauda within the dural sac. Ninth position was the midcellular diameter of the dural sac, which again is a measurement given in the reports, what we now see, but then they conveniently exclude, there are no other measurements given except for the diameter in the AP, in the sagittal and the coronal planes. Now, 9th is the midcellular diameter of the dural sac, as I mentioned here. And 10th point is the AP diameter of the foramen. And again, if the diameter of the foramen is less than 3 mm, then you can say the patient is having stenosis. So coming to the qualitative criteria, there were 7 points again, and that started with the disc of with protrusion, changes in the disc basically, and with the different grades of degeneration. Started with protrusion, extrusion, and sequestration. A lack of perineural intraforaminal fat, which I had mentioned earlier, and absent fluid around the cauda equina, serpine and or redundant nerve roots. I'll mention it again. Hypertrophy of ligamentum flavum, hypertrophic facet degeneration, and epidural lipomatosis. Now, this is a picture which depicts all those qualitative criteria which I had mentioned, and this is the presence of intraforaminal fat. And here we can find that as the compression, as the stenosis, as the severity of stenosis increases, then there is a decrease in this signal, the intraforaminal fat, the decrease in that signal around that area, and you see that it's totally absent here and there. Normally, the nerve rootlets in the cauda are redundant; they're settled at the bottom. But as as the stenosis with more compression on the cauda, these rootlets sort of get splayed, and over a period of time, if the compression is extreme, then they are displayed all over. So the presence of this type of picture of the rootlets indicates compression, stenosis, compression on the spinal cord. The same is depicted on the settling of the nerve roots there, they're redundant, and slowly you can see the nerve rootlets getting sort of displayed all over the cauda. And similarly, you can appreciate the epidural fat signal, which is a normal, and when it is severely stenosed, then that fat signal is absent. So these are the qualitative criteria to say that the patient is having the stenosis. And all these are the measurements given by the individual 27 surgeons, radiologists who were involved in the study. It doesn't make much of difference to our discussion here. And the severity of stenosis, these have been sort of unauthenticated sort of classification. We cannot call it a classification, but then the grading of stenosis, and this has not been followed very strictly. and where all features I mentioned of qualitative and quantitative criteria, they were loosely applied, and they were sort of grouped into four, saying that there's minor stenosis, moderate stenosis, severe stenosis, and extreme stenosis, where all these features are absent. There's no fat, there is no visualization of the cauda as well, and you can see the leventum flavum, the hypertrophic leventum flavum, the wet signs here. So they were graded, but then in the clinical practice, we don't follow this. And again, there are different types of stenosis depending on the causative factors. And anteroposterior stenosis was depicted because of the collapse of the disc and with the movement subluxation of the SAP. So the anteroposterior diameter of the foramen decreases, and they mentioned it as anteroposterior stenosis. Similarly, there is cephalocaudal stenosis, where with an extruded disc or a migrated disc encroaching into the foramen and compressing the nerve from below. And so they mentioned it as cephalocaudal. And circumferential, when both these factors are involved, you can say a global sort of a compression on the nerve and coming in all directions and compressing the nerve. It was mentioned as circumferential stenosis. These are not in vogue as such because, as I mentioned later, there's no consensus on what exactly causes stenosis, what level, and what are structures causing stenosis. There's still no authentic classification of stenosis. And there's a similar picture where we can see the compression being anteroposterior, cephalocaudal, and circumferential, and the MRI images, the corresponding MRI images, what you see, and this being anteroposterior. This is one cephalocaudal, and this is more of both anteroposterior and cephalocaudal, and this is complete stenosis. So when you ask us then what is the role of MRI in lumbar canal stenosis, at present there's a lack of standardization in defining lumbar canal stenosis because there are no proper measurements. What measurements we have are mainly arbitrary, and there is a total variability in description and reporting, and there is no standard guidelines which are being followed by the radiologist to give a report. And what as a surgeon, as a clinician, what we expect from the radiologist, what information we expect from the radiologist is mainly whether the stenosis is present or not, and if it is present, what is the severity of stenosis, and what is the location of stenosis, and what are the structures causing the stenosis. So now we have a sort of an understanding where we imagine that these are the structures causing stenosis depending on the MRI images, where we will add up the things, say the ligament of Fromm's hypertrophy, or there are some osteophytes, and there is collapse of the disc, and there is subluxation of the facets, and all these together are causing stenosis. But then the exact structure or the beginning of the exact structure causing the symptoms, we are not still sure of. So in stenosis, whatever the reporting is given or the measurements to be done, they should be measurable with graded cutoff values. I mean, they should be mentioning whether it's mild stenosis or moderate stenosis or it's severe stenosis. So the future, we look at the clinicians would like to have a universally accepted criteria to diagnose lumbar stenosis, which is awaited now, and that requires a collaboration of radiologists and the clinicians, and to formulate the guidelines and help us in diagnosing stenosis, and to convince the patient as to undergo the surgery in a traditional way or requires an endoscopy, to transfer endoscopy to relieve the symptoms if they are arising from the lateral canal. So this is awaited, and a lot of work needs to be done here. Dr. Gore sir has started doing much work on this aspect, and we are sure by the end of this year we'll find a proper classification and methodology to diagnose stenosis, to pinpoint the structures causing the stenosis, and then a treatment strategy will be formulated to exactly address the structures involved in causing stenosis. Thank you, sir.
Yeah. Okay, thank you very much. I think, Ravindra, you have done an extensive overview of the present present state of sort of images. If you could put this one image back, the one which was showing the gradation ABCD, please go back.
Yes, sir.
I have a comment on that. The comment is very simple. Yeah, this. Now, the comment is like this, that if you look very carefully at all these four images, they are taken at different levels of the functional spinal unit. Grade A is taken in the upper part of the foramen, and grade D is taken in the lower part of the foramen. Now, please understand that there is a lot of cheating going on because nobody knows anything about anything. I mean, people are there to confuse you and to make you feel as if they are the lords of the things and they know everything, but they don't really know. What I mean by that, I will clarify when I talk, but the only point which I'm making again, please look at grade A picture and please look at grade D picture. They are not taken at the same level of the functional spinal unit. The grade A picture is taken in the upper part of the foramen where the dorsal ganglion is seen in the foramen. And grade D picture is taken in the lower part of the foramen where there is a lateral rhesus stenosis. So I think is Shiraz there and ready with his presentation? If there are any questions, please ask. So if you have questions, please unmute yourself and ask Ravindra directly. And Nishit, I think you had raised your hand. So in case you have a question, please go ahead and ask the question.
So participants can unmute themselves, sir, just for the notice.
Okay.
They can unmute and talk.
Yeah, okay.
No, I clapped for a good lecture.
Oh, okay, okay. Very good.
Yes, sir.
So it was like a thumbs up sign.
Yeah, very good. Very good.
Satish.
Yeah.
Yeah, I just wanted Ravindran, because he just whatever light that he threw on the images was pertaining to the degenerative issue of this stenosis. I think some point need to be discussed regarding the developmental stenosis too.
Yeah. The lecture was mainly on degenerative lumbar crus stenosis.
Okay.
So,
Okay.
So that's
Just
why.
fine.
Yeah,
No, I just
See, Rajendra, what we are trying to do is we are aware of various classifications and various causes of stenosis. But a problem is, as of today, everyone, including the clinician, the surgeon, the radiologist, the MRI specialist, neurophysicians, electrophysiologists, everyone is confused. And we are actually cross-talking. I mean, when I talk, I have an image in my mind which is referring to the upper part of the foramen, and what you hear is probably the lower part of the foramen. And what we are trying to do is to change the narrative from a surgery which is posterior midline to a surgery which is transforaminal. So for some time, this confusion is expected and likely, but it should not be, because what we are talking is extremely precise. We are not trying to have mumbo jumbo as is the fashion. And therefore, what we did, that is Dr. Ravindra and Dr. Shiraz have done, is we are concentrating only on degenerative lumbar spine with stenosis. We are not talking about congenital achondroplastics, etc., etc., etc. We may as well have another program for that, but today we talk only about degenerative spine, where probably at the closer towards the development of degeneration, towards the end, we will probably come across the stenotic changes. Okay, is Shiraz there, or Shiraz is likely to join later? What is it? Shiraz, are you there?
I think Shiraz sir is not there. I was just finding the same. But I think Shiraz sir is not logged in.
Okay, no, he had called me. He was busy with some surgery, but no issues. I can take my talk and then maybe he can join later. So I would be starting my talk, but before that, if you have any questions, please ask me, or please ask Dr. Ravindra. In the meantime, I'll just set up my talk. Are there any questions? Okay, I'm trying to give my talk in the meantime. Are you able to see my screen well?
Yes, sir.
Okay.
You can make it full screen, sir.
Okay. What I had done is, there are some people who probably may have a little difficulty in understanding what we are talking. So there is a screen which shows in the lower part transcription of my talk. Are you able to see that?
Yeah, we can see that.
Yeah. So maybe this will help some people.
Okay.
Let's make a trial of this. The transcription part also is coming up. I
That's
can
good.
always make it full screen if you like, but let's try
Please.
this. Yeah.
Subtitles.
So
Subtitles.
what I'm going to do is imaging in stenosis. I'm going to talk about three things. Number one, pre-operative imaging, which helps us in planning our surgery. Number two, there will be some images which we expect to see during the surgery, which makes us sure that what we are doing is correct and the right way of doing it, or we are at the right place and the right target. And number three, some post-operative image, which will tell us that we have covered what we wanted to cover. I mean, all this I'm not going to talk in extensive way, but I'm just going to touch this. Now, the first question is, why is it that imaging is very, very important in stenosis? It is important in stenosis because all the decision making is done based on images alone. I mean, in case of disc surgery, some of the decisions in the past were done on the images, and symptoms, of course, were guiding us to the images. But in case of stenosis, there is no pain generator unless you are dealing with radiculitis plus claudication. In most of the patients who come to us with claudication, we are dealing with images primarily. So we have to be extremely sure about what we are supposed to see and what we actually do with those images. Now I'm going to show you initially 4 images which are done at this L45 level, and you can see the label on the left side image as 1, 2, 3 and 4. Number 1 is an image at the lower border of the pedicle or just below that. On the right, you see that image, number 1. This image will show you that. Now somebody asked me, how do we identify which area is the image from? So I'm telling you, the image which you see on the right is coming from the upper part of the foramen. How do I know? Number 1, we do not see the pedicles. We see that the foramina are open. We see the dorsal ganglion in the foramen. We see more of superior articular process, and the facet joint is also seen, and more or less the full spinous process and the inferior articular process is seen. You will see the difference as we go along to the other levels. Now the image on the left is in the disc level. This is what we commonly see when we are treating a disc herniation, where you see the facet joints, full facet joints, with say around 45 degrees angle and sloping towards the center of the disc. You see the dural sac, you see the dorsal ganglion outside, and on the right is the lower zone image. So the first image was the upper part of the foramen. The second image is more or less in the disc space. And the third image which I am showing is the lower zone or the lower part of the foramen. Now what is lower part of the foramen? You can see the pedicle, the lower pedicle. This is L5 pedicle at L45. You see the facet joints. You see the superior articular process overhang next to the pedicle, forming the lateral races. Now let us go back and see. In the first image, you do not see the overhang of the superior articular process. You do not see the pedicle. There is no lateral races. The foramina are open. The dorsal root ganglion is seen very well. In the second image, dorsal root ganglion is outside the foramen. There is no neural structure in the foramen. And in the lower zone, you see the pedicles and the lateral races. There are some messages in chat. Okay, can you use a pointer? Okay, I'm sorry, I should have used it before. Just give me a moment. I will use a pointer. Where is the pointer? Okay, this is the pointer and this is the pen. Okay, so we're going back and I'm just trying to show you with the pointer. Now this is, are you able to see my pointer?
Not it's.
No? Do you see the red dot which I'm showing? Okay, now,
Yeah, now it's yeah.
is it there?
In between, yeah, you can see. Yes, yes, you can
Yeah,
see.
here is the dorsal ganglion on the left foramen,
Yeah.
or actually the right foramen. This is the other dorsal ganglion in the foramen. This is the dural sac. This is the facet joint. This is the facet joint. This is the superior articular process. This is the superior articular process. This is the V is the inferior articular process. Is that all clear?
Yes, sir.
Now in this image, this is the image number 3 actually from this image. Here you see image number 1, 2, 3 and 4. So I've chosen 1, 3 and 4. Now this image on the left is image number 3. You see a small high intensity zone. You see both facet joints angulated at around 45. You see both SAP and IAP, and you see the spinous process. There are some more messages. Just give me a moment. Pick pointer not seen. No cursor can be used. That is what. Okay, I'll again try if I can make it look better. Okay, now is it better, the highlighter?
Yeah, sure, sir.
Okay, so this is image number 3, where you see the facet joint here. This is the facet joint space. This is the facet joint space. And you see SAP, IAP, and the V has narrowed. So we are in the lower portion of the foramen. See here, the V is little broader than the other image. Now we go to the fourth image. Here the first thing which you see is the pedicle, both the pedicles, and you see that the SAP is overhanging. What I mean by overhang is there is a portion of SAP which is covering the body, and this is called as a lateral recess. This is the lateral recess of the other side. This is the ligamentum flavum. This is the ligamentum flavum. Now the problem is when we talk amongst ourselves, when I talk with say Dr. Ravindra and Dr. Ravindra talks with Dr. Shiraz, we are talking with an image in our mind where I say, for example, that I went in the lateral recess and I removed the ligamentum flavum. What I'm actually meaning is I have removed this portion of the ligamentum flavum. Maybe you will be imagining that I'm talking about removing this ligamentum flavum. So there is a lot of confusion because all of us do not talk the same language. So hence onwards, I'm only going to refer to 3 zones: upper zone, middle zone, and lower zone. Upper zone is zone above the end plate of the upper vertebra. That is at L4-5. Upper zone is the area of the upper foramen above the end plate of L4. Lower zone is area of the segment below the lower end plate. That is at L4-5, lower zone is below the end plate of L5. And middle zone is between the end plates, that is the disc. Now, there is one more clarification. In the upper zone, what are the causes of stenotic symptoms? The main cause in the upper zone is ligamentum flavum, which is sitting here over the facet joint and on the anterior surface of the superior articular process. Now, this is something which no one looks at, and all traditional surgeons are absolutely 100% blind about it. They do not even know that it exists there. In the lower zone or in the disc zone, the causes could be front of the front of the epidural space, that is the posterior aspect of the disc, where there is a loss of concavity of the annulus, and there could be osteophytes here. In addition, there could be hardening of the annulus, there could be collagenization of the annulus. In addition, there could be hypertrophy of the ligamentum flavum here. And in the lower zone, there could be stenosis of this area because of hypertrophy of this tissue. Now, mind you, when we talk of ligamentum flavum, most of the people are referring to this image where they feel that ligamentum flavum here is the only cause, or the midline posterior ligamentum flavum is the only cause of stenosis, which is absolutely wrong. It is not a cause of stenosis. Let me explain to you a little further. Now, these are three zones as we call it. The blue is the upper zone, which will extend from the lower border of the pedicle to the lower border of the lower border of the body. The middle zone, the orange one, will be the disc, and the green zone will be below the end plate of the lower vertebra in the lower part of the foramen. This is a very gross picture to show you. The blue is the upper zone, orange is the mid zone, green is the lower zone. In the upper zone, the main problem is to deal with the tip of the SAP, the ligamentum flavum sitting there, and the important part is the roof of the axilla, which is here. In the middle zone, the causes are mainly about the disc. All that thinking that the causes are here, dorsal to the dural sac, in the midline, are without any evidence. You show me a single paper which will tell you that the cause is situated here above the dural sac dorsally in the midline. Then this green zone is about the lower pedicle and inside of the lower pedicle, where in the past it used to be called as entry zone for the root in the lateral races. That is why when Ravindra showed you the images, he showed you the entry zone here at the upper level, then this zone, and then this zone and this zone. So for me, it is my access to L4-5 foramen. So for me, L4 dorsal root ganglion, SAP of L5, and the axilla of the roots is the upper zone. L4-5 disc, etc., and everything at that level is my middle zone. And the green one is the lower zone, which is lower pedicle, that is L5. And here, the traversing nerve is slowly turning from being vertical to horizontal and come out of the lower foramen. I hope this is clear so that we can go ahead. I'll just have a look at some more chat images. In case MRI not conclusive or cannot be done because of phobia, etc., can we go for myelography? Yes, absolutely. We can definitely go for myelography, but only myelography may or may not be enough. We should go for CT myelography. I'm talking a little bit about that. So we go to the next image. Now, please remember that whenever we are talking about lumbar canal stenosis, there are always competing images in your mind. What I mean is, now when I'm talking about lumbar canal stenosis, all of you will have these three images in front of you. You will feel that I'm talking about laminectomy, I'm talking about this removal of ligamentum flavum, I'm talking about making deroofing of this canal where the root is going, I'm talking of this MILD, minimally invasive lumbar discectomy or whatever, lumbar decompression, or I'm talking about unilateral access for bilateral decompression, or I'm talking about over-the-top surgery. I am not talking about these things. What I mean to say is that there are competing images in your mind which should be removed. You should format your hard disk and start new, because what we are talking is our understanding and our philosophy and my system. So I'm talking like this. Now, I'm again revising your understanding. This is the upper zone. Please see that this blue thing, the foramen is open. This is the area where the dorsal root ganglion will be situated. This is the IAP. You will have this SAP, and probably you will have, this is a normal CT, so you won't see a hypertrophied ligament. And then this would be paracentral or subarticular area, and this would be the foraminal area. This is the upper part of the foramen. Some more clarification. If you see the image on the left, this plane which I have drawn along the lower end plate divides the segment. The thing above this is upper part of the foramen or blue zone. Between this black plane and the end plate here is the disc plane or the middle zone. And below that will be lower zone. The same shown here. Now, what is the importance of this image on the right side? The importance of this image is this is a dissection of a cadaver done exactly at the medial pedicle line. And at the medial pedicle line, this is the way the canal is, as is seen from midline. Please listen again. We are looking at the foramen from inside the canal. We are not looking at the foramen from outside. So here what you see is this is the nerve which is lying below this pedicle. Let's say this is L4. It is L4. This is L5 pedicle. So this is the foraminal upper part with nerve. Everything above this end plate will be the upper part of the foramen or the blue zone. Now this is the disc L4-5. Between this end plate and this end plate, the tissue which I am holding is the posterior annulus, and this tissue is almost always in front of the SAP, the disc tissue. But here you will find there is a big ligamentous tissue. This is a combination of ligamentum flavum, the facet capsule, etc. Please again remember, we are looking at this tissue from the canal, the central canal, towards the foramen. Now this is the lower part of the foramen where you see the lower notch. This is the lower pedicle, and here would be the tissue which will then involve the traversing nerve and give rise to lateral rhesus stenosis. Now here again I am clarifying that further. So if we are talking about stenotic changes in the upper or middle part, please remember on the left you will see this blue tissue is the nerve. This maroon line is the lower end plate of the upper vertebra. This bluish arrows is the disc space. And this orange thing is the tip of the SAP. And this may hypertrophy and give rise to a cause in the posterior aspect of the dural sac, as can be seen here on the SAP. Now we can also have changes in the front, as is shown on the image on the right. Those maroon things are the end plate osteophytes, and this orange thing is the posterior hypertrophic tissue over the facet capsule and the SAP. So in the upper zone, commonly we have these causes, and there is one more cause where this yellow thing, this maroon thing, and this black thing which I'm pointing out, they come together and they form what is called as a foraminal knot, K-N-O-T. Now this foraminal knot is a collection of soft tissue which is very, very hard over a period of time, and then it crowds out this nerve in the upper part of the foramen. This is not described in any textbook because they don't know. All of them are busy doing a laminectomy and fixation. So here again, in the upper part of the foramen, please see carefully. IEL is the inferior end plate line. This orange part is the ligamentum flavum in the roof of the foramen. This red is the segmental artery. The maroon is an osteophyte, and this is the nerve. So normally what will happen, the thing above this line, IEL, is the upper zone. So this has a crowding of the nerve because of osteophyte or because of hypertrophied ligamentum flavum. But you must remember that you cannot go too much cephalad in this zone because you have this segmental artery. Then in this disc zone or the middle zone, we have the disc. We may have some collagenization of the annulus, loss of concavity of the disc, which will give stenotic symptoms. And this ligamentum flavum at the back is our traditional understanding, which primarily is covering the lower zone. Please remember, this ligamentum flavum does not give any stenosis. Now we go ahead. I think somebody has asked some questions. So, okay, Shiraz has just joined, and okay, very good. So Shiraz, you may have to bear with me for some time. Now I'm just going back to this image. Please remember, this ligamentum flavum actually exists. And this is a dissection which I am showing. See, this is a superior pedicle, this is the vertebral body, this is the disc, this is the lower pedicle, IVF is the intervertebral foramen, and this is the ligamentum flavum. This also is the interspinous ligament. So this is continuous with this, and actually the ligamentum flavum then continues outside the foramen as intertransverse ligament. SAP is the superior articular process. The MP is a mammillary process. TP is a transverse process. So this is the transverse process. This is the superior pedicle, inferior pedicle, foramen, upper part of the foramen, middle part of the foramen, lower part of the foramen. But remember, we have stopped calling our surgery for stenosis as foraminoplasty. It is not foraminoplasty. It is channel plasty. That is, we are doing a plasty for the channel of the roots. That is the canal. And we are not doing a foraminal surgery only. There is a misconception in the mind of people who do not do foraminoplasty or who do not do endoscopy, that endoscopic surgeons are only doing a little bit in the foramen. No, we are doing a proper endoscopic decompression of all the zones. Now, as I mentioned at the start, in addition to preoperative, intraoperative, and postoperative images also are important. This is a postoperative image where you see that the SAP has been cut. Now, if I ask you which zone is this, you will immediately know that here you don't see the open foramen, so we are not in the upper zone. You do not see the pedicle, so we are in the middle zone, because for you to see the pedicle, you have to be in the lower zone. So this is the middle zone picture, which is shown here. This is the disc. We have cleared the tip of the SAP and the SAP, and which can be seen here, where we have cut the soft tissue on the SAP, which was causing the symptoms. Now again, I know that maybe it is not enough to clarify these things once. So again, I am clarifying. This is the upper pedicle for this level. This is the part of the body. This is the dorsal ganglion. This is the lower end plate. So this is the upper zone. But at the same time, please remember, this thing is the upper zone, which is a continuation of this lower zone, correct? So this lower zone continues as upper zone here. And the middle zone is this, that is the disc in the front and the superior articular process at the back. As an endoscopic spine surgeon, we were dealing primarily with middle zone surgery till we started going for migrations of the herniation, where the up migrated was in the upper zone, down migrated was in the lower zone, and now we are sure and mature enough to know that we can go in the upper zone, tackle the osteophyte here, we can go here and get the SAP hypertrophic tissue, and we can also drill this area. In the middle zone, we can go for the disc, of course, and we can go for the SAP. And in the lower zone, many times we go for the pedicle, we do oblique pediculectomy, etc., etc. So I hope this is very clear to you. Now, just to touch upon certain causes of stenosis, we also have this sort of calcification or osteophytosis, which could be present at both the end plates. And this image Ravindra has already shown. This is my publication, which we talk about, coronal oblique MRI, which shows you above this blue arrow is the real ligamentum flavum, which is the roof of the foramen. All of us know that the nerve goes below the pedicle and goes out. This is the facet joint. Now, this particular ligamentum flavum is absolutely 100% ignored by the traditional surgeon. They don't know. They only know that this is the ligamentum flavum which they have to remove. There is no evidence for that, except, now please listen carefully before we create further controversies. This ligamentum flavum may cause some bulging when the disc starts collapsing. When the disc starts collapsing, the SAP goes up in the foramen. The ligamentum flavum in the foraminal roof, upper part, starts pushing the nerve, and the ligamentum flavum may bulge. Now, if the collapse of the disc is too much, then this bulging also will be considerable, which may give rise to symptoms. In which case, instead of removing this, we can jack up the disc. We improve the height of the disc and thereby make the symptoms go away. Now we have come to the middle zone in the MRI. As you can see, you see both the facet joints here. This blue thing is to show you our area of interest. This is the subarticular area. This is the posterior concavity of the disc, which is normal. So this is the middle zone, the blue zone. Then on the left is the lower zone where we will slowly start seeing the pedicle, and the right figure is the lower extension of the lower zone or extended lower zone. Now, please listen carefully. In the lower zone, that is the picture on the left, we have this lateral recess. This is because the pedicle and overhang of the superior articular process. Now, this may have different shapes because of development of different tissues like trefoil, etc., etc. In the extended lower zone, that is the picture on the right, what we must remember is that there are pedicles here, there is a vertebral body in the front, and there is a lamina at the back. Now, please remember that this is a completely bony zone. This does not change. There is no stenosis in this zone unless you have a congenital problem with the length of the pedicle or the shape of the lamina. Okay, so there is no stenosis in the extended lower zone. There is stenosis in the lower zone, traditionally called as entry zone to the lateral recess, whatever. This is the middle zone, that is the disc zone with the SAP lying behind the disc. So I hope all this is clear. Can I go further?
Yes, sir.
Yeah, okay. Now again, I'm showing you the lower zone because this is traditionally has been hammered so much that we are unable to come out of that trap or viewer or maze or whatever you call it. Please see this image very, very clearly. What you see is the lower vertebral body. Let us say this disc is L4-5 with a herniation on the left. That orange yellow zone is the disc actually seen. Normal disc on the right. On the left, you have a foraminal herniation. This is the dural sac. This is the traversing nerve going out here below pars interauricularis. And this is the lower border of the disc or the lower end plate at the disc level. So this orange and the herniated area is the middle zone for a traditional person. Anything above this end plate is the upper zone where you have the exiting nerves. And now this lower zone, what is the importance of this? The importance is the nerve is now curving here. This curved area is covered by the inferior articular process here. And whatever changes which occur here can give rise to a problem with this area. So this is the entry for lateral recess. This is the entry for lateral recess. And as I told you, the extended lower zone will be in front of this. Now please remember a landmark that if you draw a line at this mid pedicle level across, then mid pedicle level is the lower border of IAP, inferior articular process. So extended lower zone is from middle part of pedicle to the lower portion of pedicle or lower border of pedicle. From lower end plate to the middle part of the pedicle is the lower zone. Lower end plate to upper end plate is the middle zone. Upper end plate to the lower border of the upper pedicle is the upper zone. I hope this is very clear. And please remember, majority of the symptoms are caused by changes here on the dorsal ganglion side, the axilla, the traversing part, or the lower portion where the traversing nerve may be going out of the foramen at this curvature. Now, this is a picture of a patient where you can see various things. On the left, you see the x-rays which fairly look normal. Now I can, sorry, I think I can paint it also, I suppose. Okay. Now here you will see the lateral recess stenosis, which is seen here again in this area. which I'm highlighting with that yellow color, which is being tackled by going in the lower portion of the foramen. Again, our cannula is in the lower portion. We are working in the lateral races. And you can see in this CT post-op where we have cut the superior articular process. You can see here in the post-op. So what I'm trying to show you is that the understanding of this picture is we are extremely clear that we are going to work in the lower zone and we are not going to work in the upper zone or in the middle zone. Maybe a little bit in the middle zone, but majority will be in the lower zone. Now quickly, I think this is my last slide. On the left is an image which you have to remember, and remember that these blue lines which I have drawn, the lower border of pedicle, the first line here, the second line is the lower border of the body, the third line is the lower end plate of the disc, the fourth line is the uh, cross line in the middle part of the pedicle, and fifth line is the lower part of the pedicle. So between 1 and 2, that is, this is the upper zone. Between 2 and 3, which is the disc, so this is the disc. I'm painting it a little wider so as to distinguish it. Below that, of course, the most wide which I'm painting is the extended lower, and between the extended lower and the middle is the lower zone. On the right is a simple picture telling you about the various sizes of the lumens, and you will find the one which is important for us is the L5 and S1. So you will see at L5, the lumen size has been shown to be 18 by 28. At S1 down there is shown to be 32, 37, 33, and AP would be 10, 16, etc., etc. So now, these last two images, these are very, very important. I'm just giving you a glimpse. These are still yet to be sort of fully worked upon, and all the secrets are still to be decided, but you can have a look. The middle portion of the image will show you the upper zone first in this part. This is the middle zone, and the lower one is the lower zone. You can see the lateral recess here, which I'm painting yellow. You can see in the middle zone a very clear the dorsal ganglion outside the foramen. In the upper zone, the dorsal ganglion is in the foramen. On the right is a AP view or a coronal view, as a common traditional surgeon would see. U is the upper zone, M is the middle zone, L is the lower zone. On the left is our view, the endoscopic surgeons. And this yellow circle which I have drawn is what is called as a cone, Cambin's cone or whatever. So what we do is when we put the needle and we go to this foraminal zone, we are able to see the middle zone first, then we extend our surgery up and down. And the last slide is this, which I have shown you before, where you see now, this is very important. You see this ligamentum flavum is extending quite laterally up to almost lateral pedicle line, as is shown just above this number 6 here. At the same time, the number 6 is showing an arrow which shows that the lower zone is empty of ligamentum flavum. On the left side of the image, you see a yellow line, which is the traversing nerve, and you see the zones marked on the roof of the foramen. The blue is the upper, orange is the middle, green is the lower. So I hope that this will help you in understanding what is the difference in our thinking and the traditional thinking. I have tried to make it as clear as possible, but I'm sure there may be some confusion because of my inability to explain beyond a certain degree. So what I would do is I would invite you to ask me questions. Either you put it in the chat window or you can ask me directly. In the meantime, I would like Shiraz to set up his presentation so that we will be able to go for that presentation soon. Now you can unmute yourself and ask me, or you can put it in the chat window. And yeah. So if there are any questions, please ask me. Otherwise, we go ahead with the next one. I will just summarize what I talked. I have told you there are 3 zones which we can reach through the foramen. I do not now call it as foraminoplasty. It is channelplasty. That is, the canal is being modified, and we are able to go in the front of the dural sac and the back of the dural sac as well as in the foramen. Traditional surgeon commonly does not go in the front of the dural sac for a stenosis. Commonly, I'm saying. Of course, you can go. I'm not saying you are unable to go. I'm saying you do not go for whatever reason. So now we'll start with Shiraz. And Shiraz, you can go ahead with your presentation, and then maybe we'll talk again. So Shiraz, please go ahead.
Yes, sir. I'm audible.
Yeah, sure. You are audible. Yeah, but your slides are automatically going in the front. Why?
Okay. And the screen is visible. Yes, I'm going on the first.
Hello?
Shiraz, your
Sir, I
voice
think-
is cracking.
Number. Now it's okay. Hello.
Yes, sir. Now it's okay.
Now it's okay. Okay.
Yes, sir.
Okay, fine. So basically, I'm going to speak about the imaging in lumbar canal stenosis and my lecture.
Shiraz sir, it
There are
is not
certain
clear.
things which we presentation, but at the same time we will try to correlate with
Hello, Shiraz
hello.
sir. Yes, sir. Your voice is not clear. It is breaking, sir.
Hello.
Audio is not clear. It's muffled and with breaks.
Okay, now.
Yeah, now it's okay.
Okay, actually, I'm in a theater complex, and I think this is the best place which I find okay for the network. So now it's okay, Ravindra?
Yeah, it's fine. It's fine. Go ahead.
Okay. So basically, I will try to correlate with our clinical presentation and the radiological picture what we see on the MRI, and then how we decide about what to do next. So basically, if you see this is the definition of the lumbar canal stenosis. So in practical means, like the lumbar canal is a fixed canal, and it's a bony canal where you see that there is something the boundary of the canal. So any of the structure of the boundary, if they got bulge of the disc or the facet or ligamentum flavum, so it will lead to the stenosis. So basically, when the patient will become symptomatic, it means now the same canal is not able to occupy, or it's not able to accommodate nice.
There's again problem with your audio.
Yeah, the
And
audio
that's
is
why
not.
so
Audio is not
basically-
good. Yeah. Okay.
Okay, now.
Now it's okay. Okay.
Now is okay. Yeah.
Okay. So basically, in a practical way, when the canal when the patient become symptomatic, it means that now the furthermore stenosis is not able to accommodate the nerve. So basically, we just have to deal with those patients who become symptomatic. So these are the clinical picture for the patient. So if you see that from this picture, the patients are better while they are sitting or they are lying down, most of the patient, unless they don't have a very severe stenosis. So it means there are some changes which happens in the canal when the patient try to assume the position, upright position. So what is that changes when the patient try to assume from the sitting to upright position. So here, when you see that, we see the enough number of patients when the patient is having very bad looking MRI, but still the patient is not very symptomatic, and even there are some patients who are having very high symptoms, but the MRI looks normal. So so in most of the patient, the radiological imaging, it does not correlate with the symptoms. So the next question is, what changes happen in the spinal canal? So basically, to my understanding, that it's the dynamic changes, and mainly the dynamic changes of the vasculature. So because of the upright position, there is a dilatation of the mainly the spinal veins, and this lead to the further compromise in the spinal canal, and that is the reason the patient become more symptomatic in upright position. And of course, there is some further ongoing ischemia and the role of some inflammation. But usually, this patient, they don't have a direct compression on the nerve, so that's why they have the MRI, which is normal. So even in those changes, we can't see on the MRI. We can see, but again, we have to correlate with the patient's symptoms. So that's why the patient examination is very crucial to decide about your next step for the patient with stenosis. So now I will just go to the basic. I will not go into the detail about, but these are the structure. So the most important thing what we have to understand is that whenever we see, we have to see that at which level this MRI cross section has been taken. So depending upon that, we can identify that particularly that part of the canal is more compromised. So like most of the time when you see the canal is more compromised in the lower part of the foramen, because the ligamentum flavum density is highest into the lower part of the foramen. And as said by Gore sir, in the upper part of the foramen, the ligamentum flavum is absent. So here, now you see this is in the upper end plate, and you can see all the structure nicely, the exiting root, traversing root, and the quadrate one and nerve root. Again, if you go little down at the disc level, you can see the other different structures. So it's very important when you are, because most of the time what we see that we just pick up one image and see, look at this image, it's very high stenosis. But no, you have to do it in a way that you try to identify that stenosis is more in which part of the foramen, and that is going to give you the very right idea. So according to now there are some nomenclature which were being developed by the North American Spine Society and the American Society of the Spine Radiology and American Society of Neuroradiology. So they have put the nomenclature for each and everything on the MRI, and how we can define and how we can do the reporting. So now this is the standard nomenclature being used everywhere. So most of the places you will get this nomenclature. So I'll just go only about this nomenclature in spinal canal stenosis. So we know that these are the different cases, different reason for the spinal stenosis. So basically, the spinal canal is a more of a round canal, or triangle canal, and you have the different kind of structures. So you have the disc herniation, you have the osteophytes, you have the ossified posterior longitudinal ligament, you have synovial cyst, you have ancillary process hypertrophy in cervical spine, you have epidural lipomatosis. So these are all the reason can lead to the further compromise in the spinal canal, and it can subsequently lead to the nerve root compression. So now what are the criteria? How what is the radiological definition of the spinal canal stenosis? So like the people use the AP dimension, then they use the cross-sectional measurement, and then you can completely do the eyeballing or visual estimation by scrolling of the MRI plates. So out of this, these are the only, these are not very satisfied criteria, and ultimately we have to see the patient symptoms first, and that's why it's very important for a spine surgeon to understand about the uh, uh, reading of the MRI, and depend upon that they can identify. So again, these are the qualitative criteria. There are some quantitative criteria, and this depend upon that they decide about the mild, moderate, or severe spinal stenosis. So in qualitative criteria, they use the epi diameter, and if it is less for the cervical spine, if it is less than 12 millimeter for the lumbar spine, then they put it as a spinal stenosis. Dural sec area, if it is 75 millimeter to 100 millimeter square, it's a relative criteria. And the neural foramen size, it also one of the way to find out the foraminal stenosis. So now there is one more modality, the stress MRI. So basically, in the stress MRI, we are trying to put artificially putting the pressure on the disc and putting the stress, and depend upon that we can decide that if there is a change before the stress MRI and after stress MRI, and that will lead to the more good idea about the spinal stenosis. So like, yeah, you can see that the disc pressure is not always same. And this is the very good slide from Dr. Faisal. And this classically shows that when you are upright, or when you sit, or when you bend, there is a big difference in the disc pressure. And this will lead to the further compromise in the spinal canal. And this can have the consequences effect. So we are trying to put the similar thing on the stress MRI. So we use the 50% of the body weight, and equally divided to each limb. And then after we take the MRI, and depending upon that, you can see on the MRI, you can find out if there is a dynamic stenosis is there or not. And this will give us a more clear idea about the change in the spinal canal after having the stress. So you can see this is the difference between the normal MRI and the stress MRI. And now there is one more modality called the spine CT and MR fusion. So the idea is, because the CT is more useful for the bony structure, while the MR is more useful for the soft tissues. So now the combination of the both, it can it can give you the more clear idea about the osteophytes or calcification, and at the same time you can have the better understanding as compared to the CT alone or MR alone. So you can see here. So this is the fusion image, and this gives a better image, because this is a combination of the soft tissue and the bony tissue both. One more important thing I want to put, that we always have to do the screening of the whole spine, because we don't want to miss out something higher in the lumbar area. So that's why our MRI's prescription should always include the screening of the whole spine, because even this will definitely help us to identify the level, that which level we want to operate, because there are so many confusion. And the best way is to when you are operating, you have to calculate the disc from the C2, and usually it's not possible to do it while you are operating. So then you have to identify that which is the second, which is the last well-formed disc. So like I always tell that my surgery is, if I am doing in a normal patient, I say it's the second last well-formed disc. It means it's L45. So that way you are very clear, and you will not miss or you will not do the wrong level surgery. So again, the same reason is because of the Barthelot's syndrome. So there may be sacralization, and the patient may have the well-formed disc one level above. So that may also lead to the confusion. So this will the MRI screening will definitely tell you that which is the exact number of the disc. And so I have just 2-3 more cases. So like this is like one of the MRI. I just did this patient last Friday. So like this is the one picture. So this is like almost a normal MRI. There is nothing. And so this patient was having the very severe pain on the right side, and the patient was not even able to stand for a minute. So usually this happens in the patient in which they have some previous disc bulge, and then they are treated conservatively. So what happens that with the conservative treatment, there is some inflammation, and that inflammation will lead to some kind of micro adhesions to the nerve. So usually this kind of patient, they are only symptomatic in the standing position. Even after some walking, they are okay, and the rest of the position, they are okay. So these are the good number of patients where you will see the normal kind of looking MRI, but the patients are more symptomatic. So we will not discuss about the management of this patient, but this is one case where you can see the normal looking MRI, but the patient is very much symptomatic. The second is like here, this is also one of the patient. He has a very big disc bulge. He's a 29-year-old male guy. So you see here, he has a myelographic block at L3-4 level. So he was very much symptomatic. So like this narrowing of the spinal canal is mainly because of the discogenic reason. So here your transfemoral endoscopy has a very good role. And in fact, we did his endoscopy, and he's very fine now. Like you see that is a similar patient. So his spinal canal diameter was only 3.2. So again, this is you can see that this is the stenosis is because of the mainly the disc reason. So doing the discectomy will definitely help for this patient. Now there are one more group of patients where you see that the patient is having classical multifactorial spinal stenosis. So you can see there is a very narrow canal, and all around is very stenotic. So here you have to work on the phlegm also. You have to work on the facet capsule also. You may have to work on the hard annulus also. So like this is the picture after we did the decompression, the patient, and this is the MRI.
Yeah.
So now you see the good spinal. This was done very
This is the
immediately.
decompression nicely.
So like my take-home message for this is that for our patient, the clinical presentation is most important, and we have to understand that by doing anything for the spinal canal stenosis, actually we are relieving the vascular compromise. So this vascular compromise is more prominent while the patient assumes upright position. So here the combination of the MRI and clinical presentation is very crucial to decide about the level, to decide about modality, and that way you can give a better result. Again, we always have to incorporate the whole spine screening, because that will always clear any problem which is above than what we are thinking at the lumbar level. In selected patient, if you do the post-op MRI like I showed you before, and if those MRI are clear, then medico-legally as well as by seeing that your spinal canal and the nerve root is decompressed, so this will be very good tool to understand that what you did is enough, and this patient is going to get relief or not. And definitely now, since Dr. Gora is very aggressive about transfemoral endoscopy for stenosis patient, and we are now started doing these cases, and definitely we can see that the lateral decompression and working on the roof is definitely going to work better. And all you guys have to believe what Gora sir said, and then once you start doing it, you will realize that this is definitely a much better way of treatment because it's done under local anesthesia. Patient is awake, so your neurology is intact, and your results are excellent as compared to any other surgery. Thank you. Hello. Hello, Ravindra.
Yeah, Shiraj. That's done.
Yeah, okay, very good. That was very nice. The only thing is, in the last case which you showed, you have shown posterior midline access. Now you have to justify that because I personally feel in that patient, a lateral racing stenosis could have been tackled by transforaminal lower zone endoscopic channel plasty. But it's okay. We can always discuss that more.
Okay, so the very simple reason for that question, that there was a very micro instability. So you can see
You see that, yeah.
yeah. So that was the only reason that we didn't want to touch, and we didn't
No,
want
but
to.
transforaminal would have been more stabilizing rather than posterior midline. Posterior midline would increase the instability because you have cut posterior tissues, etc. But it's okay. I mean, that's a point which we can always debate
Yeah.
and compare and contrast on the results later on. So now the our meeting is open for discussion, and I think we had a good presentation by Ravindra highlighting the various aspects which we need to understand in the MRI. And Shiraz told you how we correlate that with the symptoms and what are the structures which come into play when we are trying to work on those things. Now, the first question is side firing laser necessary for transforaminal lumbar canal decompression? Not really. You can use curettes, you can use trifines, you can use drills, you can use shavers, you can use the new RF which I'm introducing called Canon. You can also use laser. It is not mandatory. If you have a laser, it would be good. If you don't, it is all right. You can manage without that. Just give me a moment. I think. Um,
हाँ? पति को तो आ गया.
yeah, okay. So we go ahead with the other questions and the discussion. So I'm sorry, I was interrupted by telephone call. Now, those who want to ask questions, please unmute yourself and ask questions. Is the stress MRI same as dynamic one? I think dynamic one is done in standing position. Is it really useful? Now, Jayesh, please allow everyone to unmute. Shiraz, you please mute because you're getting the sound from your monitor.
Yes, sir. So I'm in the middle of surgery, so I will be able to answer.
Yeah, you please go ahead. Go ahead. Yeah, no issues. We will take care of that. Yeah, there is a question for you, Ravindra. Is the stress MRI same as dynamic MRI? And dynamic MRI is done in standing position. Is it really useful? And the second question is, what are the chances of root injury during endoscopic drilling?
During endoscopic drilling, definitely there's no chance of injury in the root if you are careful, but you need to follow the steps carefully. And that is more for the experienced hands, because initially any endoscopic surgeon, you need to do at least 40 to 50 surgeries, mainly only on the disc. And then as you progress, you can start with the foraminotomy, pharmacoplasty, and finally the lumbar stenosis surgery. So a beginner should not attempt doing endoscopic transfemoral stenosis surgery, because that involves a lot of understanding and the ability to reach the corners of all the zones. So it is not. It's very unlikely. We have not so far. We're not. I mean, it's not. It's very difficult to damage a root. I would say that, because at that angle, what you go, it's difficult to sort of injure the root. But if you are very flat, I mean, trying to drill the facet, trying to be a little more heroic and try to go up to the center, then there is a possibility to damage the traversing root. But otherwise, if you are careful and follow the steps properly, no chance, not much of difficulty doing the surgery.
Ravindra, could you take the next question from the chat? Are you able to see that?
Yeah.
Yeah, please go ahead. I just, excuse me for a moment. I'm attending one important phone, so just give me a moment. Please go ahead.
Is dynamic X-ray compulsory before surgery? Yes, that will help in finding out the instability at the level what you're planning to operate. Yeah, it can be an adjunct. It can give us some additional information. And whether it's, suppose if you find instability which is going to progress, then I think you need to plan for fusion rather than just doing an endoscopic surgery. So because the patient can always come back with complex in or two, and they can prefer a surgery. So if you find any find an instability which is mild or moderate, it's always good to go for.
तो अभी आपका जो वहाँ पे झमेला है वो आप सोचो, मैंने ऑलरेडी किया है, उस पे रिसीट भी दिया है.
Help to diagnose any vascular cause of stenosis.
I may have to see again. I have to
the diffusion tensor imaging. There's one aspect of doing an MRI apart from the conventional T1, T2 images. So that can throw some light into the vascular process of stenosis, because it mainly detects.
जो मैनेजर है, जो मेन मैनेजर के बाहर लेडी बैठती हैं, उनके हाथ में क्या है?
Diffusion tensor imaging can point yes, possible.
Sorry. Okay. There's a next question, that is any image help to diagnose any vascular cause of stenosis? I would say that we are not dealing with sort of non-neurogenic causes of claudication here. And if you want to diagnose a vascular cause of claudication, naturally you will have to go for color Doppler. Normally, if you have a patient who has undergone coronary artery related interventions, if the patient is a diabetic, if the patient is a hypertensive, they are most likely to have atherosclerotic changes, which can also give rise to claudication, but of vascular cause. Now, there are patients where you may have vascular and neurogenic causes together. That is also known. So best thing would be to do a color Doppler test for the vascular cause. Now the next question is, Jayesh, please unmute everyone. I mean, allow everyone to be unmuted so that they can ask questions. I mean, there are a lot of people who are messaging.
Sir, it is already done, sir. Participants can unmute.
No, they can't. I was also not able to unmute. I
No,
I
sir,
had
because
to ask again.
it was because you
Yeah,
you
now
you had
it's
logged
okay.
out.
I
Yeah.
hope it is
Okay.
okay
So
now.
sorry for that, sir. Participants, you can please unmute. You can unmute on your own.
Okay, now the next question is, does the diffusion tensor imaging help in prognosis after surgery? Theoretically, DTI will tell you which route is involved more than the other route. So if you do a single level decompression, then probably you may repeat the DTI to see how much improvement in blood supply you are having. So in that sense, it will help. Other question is for you, Ravindra. A straight endoscopic drill sufficient or a curved one is needed? And what is the size of the burr?
Yeah, we need you will be needing a curved one, the angled burr, because the straight burrs will not be able to reach you need an angled burr that would be helpful. Drilling the face.
You see, if you are able to come in line with the target, then a straight burr is okay. Angled burr is a luxury. You can always have it. Angled burr especially will help you when you go in the lateral recess, the lower zone. And the size of the burr is 3.5 millimeters at the head. I'm sorry, Rajendra, Ravindra, I had to interrupt you there.
Yes, sir, there was.
Okay.
Yeah.
Rajendra, you were saying
Okay.
something.
Now, can I ask?
Yeah,
Satish?
sure.
Okay.
Yes.
Now, there are also conventional people who are doing conventional spinal surgery listening to this topic.
Yes.
Okay. Now,
Yes.
there is something which you have brought up very, very new. Now, people have been operating in a conventional manner, like what your the other colleague has been he now changed over to endoscopy.
Yeah.
Now, there have been people who did get good results also with the conventional surgery, and there were certain patients who definitely did not show some good result. Now, is it possible for you to mark out where for a conventional surgeon, where one should be watchful that he's going to miss it?
Yeah.
Is your
I will tell
oblique
you.
coronal image the answer to it?
Yeah, one of the answers is oblique coronal image. There are 2-3 answers. I will tell you. The same question is asked by someone saying that can we get the same results by endoscopic decompression as our traditional laminectomy in spinal canal stenosis? Now let me give a detailed answer if you allow me. Number one, you must do a coronal oblique image so that you can see the upper part of the ligamentum flavum, which is always covering the ventral aspect of the facet joint and may be extending up to the upper pedicle. In some people, it may not extend right up to the pedicle, but it is definitely present in the roof of the upper part of the foramen. This is number one. Number two, you must realize that when you are doing a posterior midline surgery, commonly you look for causes which are in the lower zone and the lateral recess. Now, you are landing in the lower zone. You are not even attempting to go in the upper zone. You are not attempting to go to the tip of the superior articular process. So that is one point. Actually, both are indicative of the same issue here, that the upper part of the foramen has to be looked after. Common causes of failed back surgery are where the lateral canal or the lateral recess or the tissue in the upper part of the foramen, which is hypertrophied, is not paid attention to. So this is second thing which has to be done. Third thing, which is very, very important, is if I tell you that I can operate my patient under local anesthesia as a daycare with a stitchless surgery. Why do all that big thing like posterior midline cut and denervation of the muscle and bleeding and risk of general anesthesia and added risk of instability, added risk of dural tears, especially in canal stenosis, added risk of CSF leak, added risk of other complications of open surgery, retraction of the dural sac to go in front of the dural sac, and you cannot take care of the foraminal causes of stenosis. Obvious. All that talk of over the top and under the facet is all only make believe. I invite you to come to my theater. You do a posterior midline surgery. I do in the same patient a transforaminal surgery for the same set of symptoms. And you will find that you are way away from the symptomatic area. What you are doing is an indirect decompression of the tissue. You are nowhere near the axilla. You may be covering the curved portion of the traversing nerve where it is going down and out of the foramen. But in general, the posterior midline surgery is too morbid and it is doing too much of destabilization as compared to what we do. I hope I have covered most of the
Very clear,
parameters.
very clear. I
Yeah,
appreciate and thank you
yeah,
very much for
yeah,
having been so sharp and so clear. One
yeah,
more thing only to
yeah,
be clarified.
yeah,
In your talk, you did say the mention that when the disc collapse, the annular bulges, the ligament flavum bulges, and there could be a stenosis where things have bulged inside, and you can jack it up so that indirectly they straighten out and they definitely relieve the canal to a certain extent. Now,
yeah,
do we have an answer to this while we are operating with an endoscope to
yeah.
jack
There
up?
is a very simple
Previously,
answer. There is a very simple answer. The answer is like this. Before the surgery, you can predict it by drawing a line along the lower end plate of the upper vertebra. This line almost always goes above the tip of superior articular process, almost always,
yes,
90% or more. Now, if you
absolutely.
find that the SAP has already crossed that line, it means that the disc is collapsing, where you should look for the ligamentum flavum looking bulge or whatever. Number two is, as you know, our dilator is 7 millimeters. When you are doing endoscopic surgery, when you put the dilator in the disc space, if you find that you have to literally tap it very hard, or you find that when you tap it in, it gets stuck and it is not possible to move it, which means the disc space is very tight and narrow. That is the second indication to you. And the third indication is you should look at the open facet sign, as has been mentioned by Ravindra as well as Shiraz, which will be indicative of a micro instability, which may be chronic. Now, if you have a patient who has a chronic micro instability, commonly you will find they will have a good amount of ligamentum flavum in the foramen upper part rather than the posterior midline. And the fourth proof is that when you do a T-lift, many of us are doing T-lift unilaterally. When you do a T-lift and when you jack up the disc, I have not seen a single surgeon who is an open surgeon otherwise doing a removal of the ligamentum flavum. You just ignore it. You say that it is stretched and it becomes okay. So that's the proof that you jack up and forget about the ligamentum flavum. What I am trying to point out repeatedly is that this talk of posterior midline surgery to remove the ligamentum flavum in each and every patient and convincing ourselves that, see, I have done a good decompression should stop.
Yeah, I understand. But what I was asking, Satish, is there
Yeah.
any now implant available with the endoscope to jack it up?
Absolutely. There are multiple.
Yeah.
The one which I had introduced in 2004, in January 2004, in our meeting MISS 2004, is now coming back in the market under the name Vajra. Vajra,
Okay.
as you know, is Indra's weapon.
Yeah.
Vajra. It used to be
Yeah.
called a between in the past. There are
Between. That's what
other
I'm talking about.
expandable cages which are to be put by open surgery. They're available from Medtronics and some other companies also. So you have a couple of those cages which can be put under local through the cannula, not through the endoscope, but through the opening which we make for the cannula. Through that channel, you can put it.
Okay.
Yeah.
Okay. Okay. Thank you. Thank you.
Yeah. Now, Dr. Paras, I will reply you. I am putting my email here. And okay, before that, Ravindra, can you take this question? For bilateral symptoms of bilateral transforaminal decompression and how common?
Usually, bilateral symptoms have symptoms more on one side than
On that.
symptoms on that side. You can do a decompression on one side alone, or you need to do a biportal where you finish on one side and come back and do the other one as well. So both on the local can be done, can perform.
Yeah, next question, please.
So I have one or two words to say.
Yeah.
Yeah. Hi. Just one or two suggestions to my friends who are attending. I would advocate they should always get a fresh MRI done as close to the surgery as possible, as it is required for all medical procedures these days. So because sometimes they will start working on a few old 2 month, 3 months old MRI and there are changes which they meet during the surgery, and they get a little surprised. So that's one thing. Second is I would always suggest that they should ask for a neurogram. It helps in a way. Once you ask the radiologist, they give you a neurogram and the plexus to some extent, and that gives you lead also, like you said, all those pictures, the nerve pictures. And when you do screening, like Shiraz, this is a very good talks. All three talks are absolutely great today. The screening of the whole spine is important because you can have double crush syndrome, or there can be a major crush in the cervical or the dorsal, which you miss. It is a medically very, very vital to know. I always ask my radiologist to give a SIJ and hip is in the scan, in a corner scan. So sometime I have seen one or two avians also. So we get already conscious of the fact that there could be something going wrong in due course of time, and all steroids to be avoided in such situations. So these are few things I always say, and I try to go to scan room if there is something serious surgery or something very important. I try to go to scan room and myself do some measurements there along with my radiologist, radiographer in other words, and they give me a clear picture of where lithoperitoneum is away, this size off, and I can plan my trajectory, my angulations and all, and safety point of view. So that sometime I take a call on that. So that's my few words to my friends attending.
Yeah, that is very important, especially the mention of AVN is important. Looking at the other areas of the spine is also very important, no question. And about repeating the scan prior to the surgery, especially, I normally follow a simple rule that if the scan is more than 6 months old, or if the patient's symptoms have changed in between, and I definitely advise a repeat scan. Otherwise, maybe if the scan is say 6 to 8 months old and the symptoms are remaining same, maybe it may not be. But idea of doing the repeat scan is very, very important, because there are changes, and especially in stenosis, these are progressive changes by definition. So we can always come across some surprises. So that's very valid. Now there are okay. Okay, about the bilateral symptoms, my take is like this, that when the patient comes to you with bilateral symptoms, if you ask him a very proper history, you will find that he would say or she would say that my symptom on the right side, for example, is for 2 years, and the left side has started about 3 months back. So I have come to you. Now, the appearance of symptoms on the second side actually scares the patient, because they feel that now is the time when the thing is going to be so bad that they may land up with some paralysis or paraparesis or a urinary problem. Now, please remember today, since the topic was imaging of the spine in stenosis, we have not talked about other things. We have not talked about symptoms. We have not talked about many other aspects. Our next meeting is going to be pre-surgical planning. And before we go to that, I have a small, as I had mentioned in message to our forum, is that some small challenge. Now the challenge is all of you who are interested in what we are doing at present with all our meetings now. If you're interested, you can put in your email here in the chat window and I'll send you the challenge. The challenge will be basically 3 or 4 cases, which I will send you with all the images and all the symptom related data. Just 2 pages will be sent, or even 1 page will be sent. You can go through that and suggest your remedy. And if you are able to convince us, I mean, we are open. We accept that posterior midline surgery is important, can be done. It also solves the problem. We are not enemies with people who do posterior midline surgery. So what I'll be doing, the challenge is cases will be sent to you, minimum 3, maximum 4, and you should suggest us the solution as what you do. I mean, it may be anything. It may be transforaminal, it may be posterior midline, whatever. So all those emails which I see, 1, 2, 3, 4, 5, 6, 7. So all of you who are interested, please give me the mails. The other thing is there is one sort of you can say carrot which is being dangled in front of you. All those who are giving me emails today will also get to see my online course the first for some days, which will be free of cost. Otherwise it will be a paid course, so that will be added attraction sort of. And okay, now we again come back to questions. All those who want to ask questions, please unmute yourself and you can ask your question.
Hello, Prof. How are you?
Yeah, go ahead, Dr. Sinan. We can hear you.
Prof, just I want to ask about post-operative MRI. I mean,
Okay.
it's necessary to do it. I mean, when the exact time that you can do it, what we will see. I mean, just I want your opinion about this.
I would say that it is necessary for two reasons. Number one, before the surgery, you will be naturally counseling the patient that I will be doing this, I will be doing that, etc. So you can show the patient that you have already done it. So it increases the trust element or the trust from the patient to you. The second reason is, as you know, as we have been talking for a long time, that whatever you do, you are only relieving the symptoms, and there may be a progression of the disease process, not disease really, degenerative process. So if you do a post-op scan and if the patient comes back to you after about 2 years or so and has the same problems, you can always show him what exactly was the situation before and what exactly was the situation after. And the third thing is, for medical legal purpose or for insurance purpose, sometimes it helps to show an evidence that you have done the surgery. I mean, we have had some funny occasions where the patient's insurance payment was denied because the insurance people could not believe that the endoscopic surgery could be done through a small opening without anesthesia. I mean, just under local anesthesia. Yeah, Shiraz, what are you trying to show? Unmute yourself.
Sir,
Yeah.
we just finished the surgery. This was a big herniation. You can see the red
Okay,
tick.
very good. Yeah, very good. Yeah, very good. Thank you. That was wonderful. Okay, there is one question, Ravindra, with you. Is EMG NCV necessary for checking root involved preoperatively?
This is the same question was asked previously as well.
Yeah.
In fact, doesn't show anything specific as far as this, like what we see there will be a decrease in amplitude and nerve conducting velocity along the nerve root involved, and that it's not going to give much. The severity can be gauged a little, but I think it's not much useful and it's not routinely done.
I would say that if you're dealing with motor deficit in a patient, then an EMG would definitely help. And secondly, if the patient has more of radicular problem rather than only claudication and numbness, then EMG would help as a pre and post comparison. Otherwise, as a matter of academic interest and to make your assessment complete, you can do that. Uh, if you ask me, do I do it for every patient? No. But there's one more warning sign there, that whenever you see a patient who has um, a numbness which is present even at rest, you have to tell the patient that whatever investigation we do, it doesn't indicate that you will recover fully, because residual numbness is known after our surgery. And as we have talked in the past, you may take a long time, maybe almost 6 months to a year, to see a good difference in what the patient was talking before surgery. Yeah, then next question is, should one usually attempt to decompress exiting as well as traversing route in severe lumbar canal stenosis? Absolutely, you got it. One of our friends, Dr. Mahesh, used to say that you should at the end of the surgery have two roots, two pedicles seen very clearly. So the exiting and the traversing has to be decompressed. You should go from lower pedicle right up to the upper pedicle, but with a reservation. The upper pedicle, as I showed in the image, you have the exiting nerve below that and you have the segmental artery. So we don't go so much up. The point was, verbally, you say that from lower pedicle, you go up to the upper end plate of the disc and see that a SAP tip is free of all hypertrophic tissue. You don't really go to the pedicle. So both the root decompression is necessary. Now, in fact, this question is important. Listen, if you are dealing with a patient who has symptoms of L5 stenosis, the L5 can get involved in the lower zone of L4-5 and in the upper and middle zone of L5-S1. So you should do two-level surgery. Now, if you have S1 root involvement, then single level surgery at 5-1, where you do upper, middle, and lower zone surgery is enough. But otherwise, for L5 root, you may need to do two-level surgery, 4-5 and 5-1. The question is, time of MRI post-op, should it be 24 hours or more or less? Ideally, I would say if you're trying to demonstrate to the patient what you have done, then you can do it in within 24 hours or whenever the patient is comfortable. But remember that when you do endoscopic surgery, generally within first 24 hours, if you do an MRI, there's a lot of fluid in the epidural space, which is your irrigation fluid, which might have gone there, which also might be collected a little bit in outside the foramen. So you have to explain to the patient, and you have to also explain to the MRI fellow what you have done. Otherwise, they give a wrong report or say that there is a collection or something. And as you know, human nature is such that what is written carries more meaning than what is talked. So please talk with your MRI specialist, inform him what you have done, and ask him what is it that you want, and tell him that I am looking for this. Then you can do it in 24 hours. Otherwise, ideally, it would be okay to do it at the end of 3 weeks or so. What's your opinion, Ravindra?
Yes, sir, that's fine. One small thing I want to add here is when you're doing surgery for disc problems, you want to do a post-op MRI. So I had a small discussion with our radiologist, and they say you can do, if you do with the patient lying supine. So as you said, the collection of fluid is highlighted. So in such cases, you can always put the patient prone and do an MRI. I mean, so that effect of that bright signal will be negated to some extent. So I have not done any. I usually don't do any post-op MRIs unless required or unless demanded by the patient. So no, I don't do it regularly.
Okay. So we are coming to the end of our meeting today. Our next meeting is going to be on pre-surgical planning. And what will happen is pre-surgical planning will involve, again, a recap of everything, whatever we have done, whatever we have talked till now. We have had 4 meetings and we have had 3 meetings till yet. The first was clinical features. The first one was the anatomy, second was clinical features, assessment, third one was this imaging, and the fourth one is going to be about pre-surgical planning, which will sort of include an overview of everything what we have talked. And then, of course, the last 4 meetings are basically about surgery, the upper zone surgery, middle zone surgery, lower zone surgery, and the overview and some new thing which we'll introduce. So if there are any, okay, which outcome measure is best to be used in lumbar canal stenosis surgery? The outcome measure which we commonly use is the Japanese Orthopedic Association questionnaire, which I have mentioned before, 10 questions. Number 2, we do a post-void residue before and after, probably with a gap of month and a half. And the other thing is, of course, we do a 6-minute walking test before and after. So the patient says that, for example, Before surgery, I used to walk 257 steps, and now after surgery, I can walk 520 steps. So it's a direct measurement of what is changing, and this can help. Now, next question is repeat why L5 node needs two-level surgery. Okay. You see, L5 nerve root is a traversing nerve root at L4-5 disc, and L5 nerve root is an exiting nerve root at L5-S1. So, in the portion of the nerve in the lower zone, that is below the end plate, upper end plate of L5, in the lower part of the foramen of L4-5, you can decompress when it is entering the lateral races. And at L5-S1 foramen, you can decompress when it is coming out of the foramen by decompressing the tip of the superior articular process and the hypertrophic tissue which is lying there. That will help. Okay, now I would like what we did last time. I would like a couple of you to unmute and have you give your comments or your observations or suggestions or anything which you feel is relevant to our talks. If you want to criticize, you're welcome. Please let us know. I would like Dr. KSRS Prasad. I have seen you after a long time. Of course, I think you were there last time. Then I would also ask Dr. Niaz. I would also ask Dr. Sandeep Duhan. He wanted to probably speak something, but he unmuted and again muted himself. Anybody else? Dr. Faisal, if you have any comments, please go ahead and let us know. And then Dr. Fasihi, if you are there, you're welcome to comment. Unmute yourself and give your comment.
Hello?
Yeah.
Hello?
Yes. Yes. Dr. Obaid, please go ahead.
Thank you very much, Professor Gori and the other team. It was very impressive talk, really, and quite clear. I found this anatomical, surgical, and landmarks of upper and middle zone is quite clear. And I think it will explain all the aspects of stenosis. And I really impressive with this talk, and definitely this is a new classification. Thank you very much for this talk. 12 years and very useful.
Yes, thank you very much. Thanks for joining us, and we hope that you will be there for the next meeting also.
Sir, there is one question in the chat box, sir. Is neurogenic claudication score also helpful? By Dr. Bifak.
Yeah, I saw that question. It will be helpful. You see, what we have to remember is that whatever we have been doing traditionally is definitely helpful. We are not saying that you just forget everything and just only listen to us and remember what we say. We are saying that we are trying to modify primarily our access, and therefore probably over a period of time, we will be able to come out with our own outcome measures. In the meantime, we will probably do the same outcome measures. We will also do claudication score. There are various claudication related questionnaires, Zurich questionnaire, these, that. You can also do McNabb's, which is used commonly for our disk related thing. You can use SF36. You can use, I mean, whatever you feel is proper to show before and after can be used. So neurogenic claudication score is helpful, definitely. Now, we are waiting for our other friends to comment, or otherwise we will be stopping now. So what I'll do is, if there is no comment in next 30 seconds or anybody wants to unmute and talk, please go ahead. Otherwise, I hand over the mic to my colleague Ravindra, and we say thank you to Jayesh and our team, our friends from Alembic, who have helped us in all these meetings till now. and who have promised to help us in the meetings ahead. So thank you very much to our team. And I would give the lead to Dr. Ravindra now.
Thank you, sir. Thank you very much for allowing us to share the platform, and thank you to Jayesh for doing this. It was very helpful to not only to us, to many of the delegates who can get lots of knowledge. Thank you so much.
Yes, sir.
Chirag
Jayesh here.
wants to say, yeah, please go ahead.
Yeah, sir. No. If Shiraz sir is there, then I'll conclude after Shiraz sir. Not an issue, sir.
No, not Shiraz. Chirag, I said. Chirag
No,
Modi.
Chirag sir, I think is on mute mode. I'll ask Chirag
Okay.
sir to add something. Chirag sir, are you there? Hello, Chirag sir.
Yeah, Amit, you want to say something? Amit Surana?
Yes, sir. Yes, sir.
Yeah, go ahead.
Yeah, am I
Yes.
audible?
Yes,
sir.
you are.
It's a very good concept of changing from coronal to sagittal plane surgery, which you have been mentioning since last three talks. And then again, one more important topic that you mentioned today about the coronal oblique images of the MRI, because many times I did posterior midline surgery and still the patient had some few symptoms of claudication and pain, which were really not explained by the MRI. But this oblique MRI I have started doing, and it's really explaining the things that yes, there is some foraminal or upper zone component which is remaining after surgery, which was not addressed with the traditional surgery. So I think this is a very important thing to approach the root as per as you said today, like the L5 root needs the lower zone at L5S1 and upper zone in the L45 lower and L5S1 upper zone. So these two topics are very important for today.
Right. Okay, very good. So, Jayesh, sorry we interrupted you. You can again take over.
No, sir, it's totally fine. Actually, I think Chirag sir is not audible right now.
Yeah. No, Shiraz has left. He was busy with the surgery,
Yeah.
so he has left.
Oh, sir, I'd like to take this opportunity to thank yes, sir, Satish Chandra Gori sir, Ravindranath sir, and Shiraz Ahmed sir for this excellent talk on imaging and stenosis. And I'd also like to thank all the participants for making this seminar and very interactive one. And I hope we continue to participate in the forthcoming events as well from the Mission Spine Foundation, which is on Saturday, as correctly said by sir. Timing would be same 3 to 5. So we'd again connect on the same platform with the same ID and password. And once again, sir, thank you so much for giving us an opportunity and believing in us to conduct this CME. And it is very much valuable to all the participants and for me as a participants to learn something from a non-medical background. So once again, thank you, sir. We hope you all stay fit and fine, sir. Thank you so much, sir. Have a great evening.
Thank you very much. Yeah, have a good day and see you again on Saturday, 3 p.m.
Yes, sir, definitely. Thank you, Ravindra sir. Thank you, Siraj Ahmed sir. Thank you, Gori sir.
Okay, bye-bye.